All right, our next session is going to focus on a little bit like case studies, but we're trying to do some drill down as what makes for a successful on-site, near-site center, particularly for large and smaller employers. You know, what kind of similarities are there and what kind of differences? And so I'm pleased to have representatives of a variety of different groups with us. So Joe, let me start out with
That's mine.
Okay. So Scott, why don't you introduce yourself then, please?
Okay. Good afternoon. My name is Scott McIntyre. I'm the benefits director at a place called Oak Ridge National Laboratory. It's in Oak Ridge, Tennessee. We're the prime contractor for the Department of Energy. It's kind of a small college campus. So when you hear me talk today, kind of why we did what we did, we're set up. We're very secure. So you cannot just drive up to my office. You have to actually be cleared and badged, so the general public cannot get to where our employees are. 6,500 employees. If you've seen Oppenheimer, our sister lab, Los Alamos, was mentioned heavily in Oppenheimer. We are very similar to Los Alamos. We were started at the same time back in 1943, so we're celebrating our 80th year this year being in existence. I think I mentioned 6,500 employees, very similar to a small college campus. A lot of scientists, a lot of highly compensated employees, a lot of engineers. One of the big things we're sort of known for right now is our supercomputer frontier. My medical director was supposed to come, Dr. Rary, but she could not. And this is kind of what our clinic looks like, our on-site clinic. We've been in business for about 5 years now. We've got one medical director, 2 nurse practitioners, 2 RNs, 1 MA, and 1 front office assistants. And we're pretty much what I kind of refer to as primary care plus. That's who we are.
Hello, my name is Dan Ludwig, Director of Benefits and Safety for Breakout Brothers. We are a chicken processor headquartered in Westfield, Wisconsin, also with locations in Wells, Minnesota, Irving, Texas, and Knoxville, North Carolina. We've got about 2,300 employees. We have 2 operating health centers right now. We're in the process of opening our 3rd health center as we speak. We've been doing the health centers. We first started in 2016 and have been doing actual on-site services since 2007. So looking forward to being here today.
Thank you.
Good afternoon. My name is Kenneth Aldridge. I'm the Director of Health Services for Rosen Hotels and Resorts, Rosen Medical, Rosen Care, anything Rosen. So basically, I don't have slides. I wish I would have. But Mr. Rosen and Rosen Hotels, we've got 7 hotels in Orlando, Florida. We've had our own on-site health centers for about 32 years. So we've been doing this for a little while. But just like everybody else, our on-site health center is advanced primary care with imaging, physical therapy, chiropractors, a little bit of everything for our about 4,300 covered lives that we have under our health plan. And then we've also taken on some responsibilities with some municipalities. We took on a health system that we were able to save them $46 million in 3 years by changing the infrastructure, bringing in the integration of the health insurance with the health center and maximizing health outcomes and making the services more accessible and lowering the cost of care for their overall employees.
Great, thank you. Joe?
Yes. My name is Dr. Joe Thomas. I've had the honor and privilege to work with Nucor Steel, running several of their on-site medical centers that basically myself and my wife started years ago. The picture here is the one that I currently run is in Darlington, South Carolina, the original steel mill for Nucor. And basically, we got there in April of 2008, and by October of 2008, they already had an on-site center up and ready to go. Subsequently, there's another Nucor facility in the local area called Lovecraft, and we've added them. But basically, if you build it, they will come. And I actually wear 2 hats, so I do all the occupational and the primary care, or as I like to say, concierge urgent care for the facilities there. And Recently, during COVID, I got licensed in North Carolina, Virginia, and I run an on-site facility for a very small facility we have up in Virginia with a nurse up there and a kind of a unique device called a MedPod, which basically you can do exams remotely with the assistance of the nurse. The salesman says you do everything but touch or smell, and for my days in the ER, I need to smell a patient. And you can use the nurse or actually the patient to do the feeling from the palpation if you need to. But they were at one time working with gloves that would be able to be transmitted that information remotely.
Great, so let's start out with Joe. We'll start with you. How do you define success for the Worksite Center? What were your objectives?
Primarily was to make sure that people felt comfortable coming and that they knew that if they saw me for a non-work related event, that it was confidential. It was just like if they'd come to see me 10 miles away. And the convenience of working for an industry that's primarily male-based, it's very difficult to get men to go to the doctor. In fact, I coined the phrase, men don't go to the doctor, they go to the mortician. And so we really had great success early on. And in fact, there were almost 500 employees, and there was only one employee out of that entire group that I never saw at least once, or didn't use the center at least once. And I don't know why she decided she wasn't going to use it, but right before she retired, I said, Kathy, you've got to come down to the center. But she never did. But it was very, very successful initially when we started in 2008 until 2016. Some things changed, and we may talk about later.
Thank you. Ted, how do you define success and what were your objectives?
You know, when I look at the health system in our health center, I really look at, my clinical degree first, and just remembering bringing on services like mobile mammography or mobile dermatology, and finding things that we would not have done before. An example was we had a 47-year-old female that we at Rosen Hotels will reach out to the members and be as proactive as possible. So right when they come onto our health plan, we're coming to ask them, come in and get screening labs. Let's know where we're starting. And mammograms are part of the piece of that puzzle. And we had a 47-year-old female brand new to our health plan, brand new to our medical center, and said she'll never get a mammogram. It took us 3 months. She earned our trust. We were able to walk her through the mammogram bus, got her to do a mammogram, and guess what we found? We found breast cancer. So I look at success as, what are we going to find? How do we save lives? We implemented our mobile dermatology program, and the first event we found a invasive melanoma, and so far we found 3 melanomas, and that was at the municipality where we saved that $46 million. So when I look at it, I break it into components. First, clinically, the lives that we save, and then from the business perspective. We've saved, under Rosen Hotels, about $540 million, which is a nice chunk of change, which helps us buy or build more hotels and provide more services. So breaking it up into those two components, first and foremost, is all of us in this room are saving lives.
Thank you, Dan.
For us, it really comes down to defining what reasons you put in the health centers or your on-site services in the first place. And it's not necessarily the same for each location. For our original health center, our original on-site services, it came down to we were seeing continual double-digit increases in our health insurance costs every year. Made the decision that we need to become self-insured. Once we became self-insured, it was how are we going to control the costs? And one of those was to start providing on-site services. So when we said, okay, we're going to do on-site services, the main thing we're looking at was, are we going to actually start to control these costs? And if we're going to control those costs, can we then pass those savings on to the members? That also morphed into complaints that we were hearing from our employees, our members saying, hey, I can't get this service or I can't get that service. So then it's, okay, how can we do this better than they're getting it out there traditionally? So it's not just about, the return that we get, but it's also about improving the experience for our members. Then we look at another location where they've got a relatively, actually a very low loss ratio for their health plan. it wasn't about, okay, we need to get a return on that. For that, it was about, let's improve the employee experience for the person and make sure that they're getting the care that they need. And one of the things that we were concerned about is that they were under-doctoring. And from there, said, okay, we need to start making sure that they get the right care that that they need. And sure enough, we were able to identify a lot of undiagnosed chronic conditions. So it really came down to defining success is making sure you set what you're looking for depending on that location, whether it be you need a financial return, whether it's you need to make sure that people are getting the appropriate care or they're getting better access to the care.
Thank you, Scott.
So I'll echo several of those things. One, we're predominantly male also, and also being our location, convenience was a really big factor, and just the employee experience. Because if someone went to a physician in the community, they lose a third or maybe even a half a day. But now they can schedule an appointment, walk across the street maybe, or walk down a block or two and be seen and be back at their desk in a very short period of time comparatively. And like I said, we have a lot of scientists, a lot of engineers, they want to get back to their work. That's kind of their driver. And being male, they did not want to take up half a day to go into the community to seek their care that they needed. Also, we looked at it a little bit, kind of a lot of chronic situations, and getting people to the right physician at the right time in the right place. So our clinic kind of serves as a gatekeeper for referrals and making things happen just a little more timely and a little more efficiently than they would do if someone even saw their own primary care physician in the community. It may take a little bit of time to get in. So that's how we looked at it.
So Scott, let me start with you. How did you determine what services to start out with and the staff that you offered? And what caused you to expand with result?
So kind of who we are. We do have an occupational clinic also, and it still in existence today, and that is ORL employees. And they did a little bit of acute care, so like a sinus infection or something like that. They would treat, maybe see you one time, and that would be it, and refer you to your primary care. So when we really started looking at it 5-6 years ago, we were like, what should we offer? What can we offer? And it was like, there was definitely some reluctance from the employees to be seen by an ORL employee or an ORL medical doctor because just privacy, conspiracy theories, all those good things come into play. So we really looked at it and said, we call it primary care plus. Really, what can we offer? And let's do the biometric testing. Let's do the annual physicals and start there and expand if we need to. And it has really kind of taken off with just getting people just to do the basics and know the basics and get that annual physical and start and uncover, kind of like a few of us said also, what are we going to uncover? And, we've uncovered some things that, doesn't necessarily surprise us, but obviously probably surprise the employee also. So that's kind of how we determined what to do.
And what kind of staff did you start out with and where did you end up with?
So what we started with was what we still have. So we started with the one part-time medical director and then the 2 nurse practitioners. That's how we started and that's what we've maintained. We started in 2018, had a slow build-up. We're rolling along pretty good, and then March 2020 hit. Out of the lab itself, out of 6,000 employees, about 3,000 went home and 3,000 had to stay to keep it running. And we got creative at that time. We did some telehealth. We let the nurse practitioners talk to spouses about themselves and about their dependent children. We looked at some other things at that time that just didn't come to fruition, but we explored avenues to see, hey, where's this really going to take us? And then we push, and we're an on-site employer. Everybody's come back to work, and we've been back to work now for a year and a half, 18 months have come and gone real quick. And the utilization has increased tremendously as we've gone back up. So,
Great, thank you. Joe, let me ask you, what services did you begin with and what kind of staff yourself? And what have you added over time?
Yeah, initially, it just started kind of like the primary care. I run primary care offices before. But I was also more in emergency medicine, so we did some involvement early on with occupational. At the time, I had myself and I think a part-time nurse and maybe a phlebotomist. And we really started, the initial center was near Charleston. And I literally started in a closet and knocked down the wall, and I had a closet storage room. And I was doing mainly wellness exams. And health and safety guy. I said, well, doctor, you see people for episodic illnesses. So I started doing that. The thing that really put fuel to the fire was when we started in South Carolina, a physician can dispense. So we had on-site medications. The numbers just started to go up and up. And so I went from that facility in Charleston and expanded up to Darlington, the oldest location for Nucor. And there was just no primary care there. And I was fortunate enough to have my wife work with me, who's an excellent nurse. And we just kept adding services that came along. Like we do home sleep studies. We do all of the drug screens, the wellness labs, and anything I can find something to add. We save the company a lot of money by using vendors for imaging services and some other services. Even though we have Cigna as a third-party administrator, they're not as efficient as going straight out and getting that service from someone else. We get our CPAP machines and our supplies directly from them. So it's kind of like if you see a need, fill it in. I serve as a medical review officer. I also serve as a professional supervisor for the hearing program. So just anytime you can add something else, because I'm really working with small divisions. Probably some people say it's too small to really have an on-site facility. But the total population is somewhere around 900 between the two divisions that are very close, and that was about the same population as Planned Parenthood. Right now I have a nurse at one location, I have a nurse and a receptionist at another location, the one that's the largest, and then I have a nurse remotely in Virginia.
Thank you. Kenneth, how did you start out with your staff and where you are today?
So remember this 32 years. So 32 years ago, it was a part-time position, part-time MA, and part-time admin to where we are today. As we continue to grow, we're up to, we had about maybe 700 square foot facility to start off with. And eventually, I think we nagged Mr. Rosen enough to finally build us our own 12,000 square foot facility. So now we have MDs, DOs, nurse practice, PAs. We have podiatry, chiropractic. We have on-site labs, just like Dr. Joe. We have imaging facility. We had to stop our ultrasound during COVID, and that vendor went out of business. So if you guys know of any mobile ultrasound that's out there that does transvaginal, because according to our data, we do a lot of those, please let me know. And we've added the mobile dermatology this year, like I had just said, because we saw in the data that our population, which 35% of our population are coming from third world countries where they don't have transportation and those type of things. So the more we can bring in, just like Dr. Joe was saying, we do, just like physical therapy. We saw in the data that our population was not going, and so when we were building our facility, it was okay, do we do dental? Do we do physical therapy? And physical therapy won out at that time. Well, what am I working on now? Well, we have the mobile derm, we have the mobile mammo. I just last week met with our mobile vision, and then now I've been working on mobile dental. So right outside of our 12,000 square foot facility, I'm excited that it's going to be like a mobile, those vendor truck events. And imagine, it's just like one of those executive physicals, one of those costs 10, 15,000, where you get everything done in one day. But imagine your associate, a housekeeper, secretary, who do not have the ability or opportunity to get away from work, just like Scott was saying, it does take time. But guess what? Our company will pay for our associate to come to the medical center, they'll stay on the clock, we'll provide the transportation, and they'll come in, get their blood work, see the physician, get their physical, get to see physical therapy, imaging, get their mammogram, dental cleaning, all of those things. Maybe a half a day, and some of the staff were like, God, when will we stop? Well, I think when we can do dental cleaning and do a colonoscopy, I think that'll be great. Not with the same equipment, obviously, right? But we're almost there, where we don't have to do obviously colonoscopies are the gold standard, but there's liquid biopsies that are out there now. So there's no reason why all of us can't get to 100% compliance on colorectal cancer screening. None. So now we're almost there. So when we get back to the office, I'm really excited to be able to, take pictures and maybe one day have slides where you can see actually those events going on. And hopefully we'll be at that CRC screening of 100% and our population getting the services that they need on a day. That's where, like Dr. Joe said, when you see a gap in your data, in your population, and why did we do the mobile, we want to do the mobile dentistry? Well, I've been asking for this for a little while, and we had a patient that had endocarditis, and started diving deeper into the data and realized that that patient never got his teeth cleaned. And so I started diving deeper into the data, even though I was told, Kenneth, that's not in your wheelhouse, just, let it be. Well, guess what? Now it's in my wheelhouse because we dished out $60,000 for that member. The member is doing great, but that's $60,000 we didn't even spend. So we got to bring it to our associates, bring it to them, and they'll get it done. Did I answer the question?
That's fine.
Okay.
Dan, how did you start out with services and staff and what do you got now?
But it's hard to top that.
32 years.
32 years, yes. We've been at it a lot less than that. Also, smaller. Our largest campus is about 1,000 employees. We got started out in 2007 with physical therapy. And at that time, we were fully insured. So one of the big drivers was really controlling the occupational MSK risk that we had out there, which was significant at the time. We were having over 50 work comp injuries that were directly related to soft tissue. I lift this and it hurts. So we started out with physical therapy with the idea of, hey, if we break even with what we save on work comp, you know what, there's going to be other benefits that the employees are going to love it, and so there will be some hidden benefits associated with that. We were amazed at the results. We drove down over 90% of our soft tissue injuries in a short period of time, more than paid for the entire cost of the program. But that gave us the confidence and the realization that, hey, having on-site services really is a benefit to both our employees as well as to controlling some costs for the employer. So when we became self-insured was when we started adding additional services. So we added primary care in 2016, and then from there it was based on, okay, what are we need? What are we hearing from the providers in regards to what he's seeing out there? So we started adding a mobile mammogram. We added sleep studies. We added ultrasounds, x-rays. Mental health came a couple years ago. That's really gone off. We started just before COVID. Took a little bit of a break, and now it's ramped back up. But we're seeing these services that we're hearing that are needing, and that we discussed, okay, can we do that here? The on-site dentistry, we've heard that from multiple times today. That's something that we're actively looking at right now as an additional service that we're going to add on. So we've added quite a bit for a relatively small employer. We're still looking at other things that we can add.
Scott, how did you get started and where did you go?
I think I started.
You started, okay. All right, so let's start with Ken. Yeah, sure, Ken.
Larry's going to not ask me up here again, but the cool thing, Dan was just talking about mental health. We just started our mental health 2 weeks ago, but as we were rolling this out, I told everybody via email, or just as we were talking about bringing the mental health into the medical center, I said, you know what, I'm going to be the first patient. A lot of people thought I was joking, but I wanted people to understand, hey, running health systems and healthcare is tough. I mean, look at the amount of attacks on healthcare workers that are going on. Nationwide, 20% of healthcare workers have left. Well, we brought mental health in, and we just started it on August 22nd, and I was one of the first patients. So make sure you guys, I know that many of you are out there, and encourage your associates, let them know if you are getting services so that they understand, hey, let's fix this mental health issue and breaking the stigma. It's important.
Yeah, I meant to add on, we talk about services. Real important thing that I added relatively recently was like physical therapy. And Allie Hartman right over here with Proactivity has really been a wonderful thing because all of our workers, most all of our workers, are doing a lot of physical activities and some musculoskeletal concerns, and having the physical therapy right there and not having to try to find an appointment that's located far away has been very wonderful.
Thank you. Dan, would you tell me, how did you get initial buy-in from your C-suite, and how do you get the trust and buy-in from the population?
First, you have to identify their pain points, and some of it was the dollars that were going out the door. Like I mentioned with the physical therapy where we started, it was easy to look at the claims dollars to say, this is what we're spending on soft tissue. We can address this by bringing in this particular service. And then it makes it an easy equation to say, okay, yeah, we can save that by doing that, plus we're going to benefit our employees. It makes it easier to get that buy-in. When you start looking at the other services, you still have to look at those particular pain points to find out, okay, what is it that they're needing? As I mentioned before, high cost of healthcare coming in, and what can we do from a primary care standpoint to address those particular issues? And it made it easy from the C-suite standpoint. It actually came to a point where down in our Irving facility where they had a loss ratio of about 0.6, they said, well, we want a clinic too. And I said, okay, that's fine, but it's going to be difficult to, in 3 years, come back and say, hey, look at this great return when you consider that your loss ratio was so low to begin with. So let's talk about other reasons that we're going to do this clinic. Is it because that we want to provide better care for our employees, we want to improve retention, whatever it may be, we need to make sure we're discussing those ahead of time. In regards to how do we get the buy-in from our employees, the number one is making sure that they have a good experience with the provider. I always say that our employees will send out drones, cross the fence, tell us how it looks on the other side, and report back to us. Well, if those drones go across and have a terrible experience, they're going to report that bad experience back, and we're going to get terrible utilization. But if they go over and say, hey, it was great, you should try it, then it starts to spiral into the right direction. So it really comes down to the experience that the initial people, the first early adopters have, and they go back and report to everybody else.
Scott, how do you get buy-in from your C-suite, and how do you get people to utilize the center?
So very similar to Dan, what was the reason for setting it up? And one of the big reasons, which I've already kind of said a little bit, but was really convenience. It's one of those things that's really hard to measure. It's hard to measure soft cost. It's hard to measure productivity. But there was definitely a view into that says, we need something to help us in that area. So that was kind of one of the reasons for buying it. Also, even though the medical director for the clinic is not an ORNL employee, truly a vendor, we don't have a CEO. We have what's called a lab director, which is the same thing as a CEO. Very scientific mind. I put those two together, and the medical director able to communicate and talk scientifically with our lab director was very important in that sense, and they understood each other. And then also he became a utilizer of the clinic and had a positive experience. Kind of goes back to what was said is word of mouth is like, if you have a bad experience at a restaurant, you're probably not going to go back and you're probably going to tell 6 friends, and they're not going to go to that restaurant. So we feel like the same mentality. That's kind of what I've told the clinic is, one bad experience is really going to impact you because, you sit in tight, close quarters, you sit in cubicles, and you're going to share that. While the reverse of that is a positive experience is going to go a long ways too. They're going to tell their friend or their coworker that, hey, I went down there for a physical and it went really well. And that's going to spread. So we really feel like word of mouth and the experience, as Dan said, the employee experience is really key to ongoing and getting that buy-in because, the world we live in today, people are not afraid to express good, bad, or indifferent. They definitely like to share the bad. And if any of you are benefit managers in the room, you hear more of the bad than you do the good. So that's our goal, is to make sure that service is top-notch and that employee experience matches that. And we see that in our survey data. That's kind of how we measure this. We really look at, it's not so much the cost is one factor, but if the employee experience is taking care of itself, the cost savings is coming also. So we really look at the survey data that we receive and make sure that is top notch.
Thank you. Joe, how do you get the C-suite buy-in, and how do you get people in the door?
Well, first, I'd like to say that at least to my knowledge, Newport was never driven by looking at the economics. I really didn't believe that what they thought was they were doing the right thing for their employees. And what I found, so I'll tell you the good story and the bad story, was buy-in from upper management is so important. When we first opened the facility in Darlington, the general manager was getting allergy shots, so he was always going to the center, and so we had a real good, positive experience there. And like I said, one person that had a good experience would tell one or two, and we had days when by myself would see 50 people, and that was hard to do. But we kept building the center from 2008, and we added those services. We had a weight loss program, we had a health coach, and in 2016, we had a general manager that came there that did not believe in on-site medical care. And so he thought it was an entitlement, and he basically undermined everything we'd done. He got rid of the weight loss and wellness component to the health coach. One day, when he wasn't real pleased, I had a lot of friends in the corporate office, he didn't like it. And so he said, there are two things here, Dr. Joe, and I can close. One's the cafeteria, the other's the medical center. Well, 3 months later, they closed the cafeteria. So it really was a very adverse work environment, and our center was really harmed greatly. And right on the heels of that, right before he got fired, we had COVID. And so now I'm in the midst of trying to rebuild the facility. And we're talking about colonoscopies. And one thing that's nice about a small division like I have is actually came out in Scottsdale, and there was a roundtable discussion about a blood test that is going to be hopefully approved for colon cancer screening. And the numbers were really impressive. If the FDA would approve it, Medicare would pay for it. So at the end of the meeting, I went to the guy and said, would you work with me from the standpoint of, let me get, basically I'm satisfied FDA approved, but I would like to see if I can utilize this for my facility there in Darlington. So I went back and another supportive general manager said, Tom, I'd like to get, if you look at the national average, over 50% of people don't get colorectal screening. And I said, what I'd like to do is I'd like to get the team all, as much as I can, all get up to date on colorectal cancer screening. So I got a spreadsheet, and I started at the oldest team leader, and we worked our ways from, I think he was 74, all the way down to 45. And before we started this initiative, we had a 34% compliance. And at the end of it, I had 93% compliance. And what I did was, I had my receptionist call each individual and say, when's the last time, are you up to date on colon screening? And if they weren't, then she would say, well, Dr. Joe, and we really want to try to get everybody up here, it's a very important thing to do. And would you agree to do a colon screening? And if they did, then I'd set up everything and she'd go down the list. The ones that didn't agree to colon screening for colonoscopy, which will always be the gold standard, I called personally and said, I respect your decision to not have a colonoscopy, but would you consider a blood test? And I had nobody that responded that refused the blood test. Now, we had 16 people that we could not get in touch with. That's why we didn't get toward 100% to force those people to do something. But it was really a real pleasure to be able to do that, because you got a group that you can get in touch with. And so there's some good things about being small. The other thing that I think is important while we're on the subject of on-site medical centers and saving money and saving lives is my feeling is this: your health, the number one person that's important to is you. The second person in line is your family, and I would argue that your employer is the third most important person for your health to matter to them. And if you think about it that way, it's just the right thing to do.
Thank you. Kevin, how did you get C-suite approval, and how do you get people to do it?
Well, the first part was easy. He told us to do it. So I was still in high school when that first happened, but that decision was economics. I mean, back then we were fully insured and then got the double-digit increases. Basically, long story short is you don't tell Mr. Rosen that he can't do something because he'll do it. And that's when he took one of his offices, the accounting offices, and turned it into a clinic. I mean, that's when we got started. So basically, he said, do it. You know, the buy-in from the patient population, I mean, it all begins with trust. You know, and unfortunately, trust in some of the medical profession has decreased over time, but it's really bringing them in and helping them understand that their information is going to stay confidential first and foremost, especially when, you know, you have the name of the company on your building. You're thinking, guess what? My employer is now going to know that I need a heart transplant or a bone marrow transplant or whatever it might be. We from the Rosen Medical Center, it does not cross our barrier. Mr. Rosen, he'll ask if hey, this person's okay, and I say, yes, that's it. He's not going to find out any details or PHI or any kind of, you know, we have to stand up and stretch the
You touched the wrong button after.
Yeah. My opinion is exactly. Yeah, it all begins with trust. And so that's where we bring them into the facility and help them understand you know, how we are separate from the company and it stays confidential. But we do know who's in the hospital. We know who went to the ER through our ENS system. All of those things to help us manage our entire health system from the medical center and integrating it into our insurance. So getting that buy-in from the patients, it starts with trust, just like with that mammogram with that 47-year-old that I told you about. It begins with trust.
Again, side note, if you want to submit questions, text them to me at 847-606-5527. Kenneth, how's the patient and the provider experience different in your center as opposed to community?
Well, I know one of the presenters earlier was talking about the 7 minutes. Well, that's just ridiculous. You know, we have longer times, or our physicians and APPs can spend it with the patient to get to know them, understand them, give them time to listen. Do you guys, you know that I think the average time from the point that the patient starts talking about their problem, the national average is, it will take 17 seconds before the physician cuts them off. And then you guys got to know that 85% of the diagnosis is going to come right out of their mouth, but we don't give them the time. We got to give the physicians and the providers the time to spend with their patients, that they'll find those pieces, social determinants of health, the depression, the anxiety, whatever it might be, so that you can take care of them at the point of care. That's really a big difference. But again, bringing all the services into our facility where we focus on access, quality, service, cost, and innovation. I mean, those are the key points for us.
Thank you, Dan. How's the patient experience and the provider experience?
I'll echo that. I think it really comes down to you're going to get a lot more face time with your provider. It's been a long time since I've been out and got care outside of our on-site clinic, so I'm trying to remember what it was like. But I remember the provider being rather distracted, and that it wasn't a whole lot of me talking or him talking. It was in and out, and that was it. But then you go and you sit down in our on-site clinic, and it's more like this, and there's a conversation, and he's not jabbing away at the computer. It's, I'm going to listen to everything you say, and we're going to have a dialogue back and forth. So from an employee or patient stance, it seems like I'm really listened to from the provider. On the other end, I then, you know, when our time is done, I always get a chance to say, well, hey, how things going with the clinic? Because not only am I, a patient, but I also have to manage it at some point in time. And the feedback that you get is that there's not this sense of, driving how many, what do they call them, RVUs, there we go, I was close. Are you making sure that you're billing enough? Are you seeing enough patients in a day? There's not that pressure to do that. It's more about, can they provide the care? So the feedback that I get from the providers is they feel like they can actually practice medicine the way that they want to practice medicine.
Scott, how's the patient and provider experience different?
Very similar. And one thing that addition to the face time is something that our clinic does that helps patients is they'll make that next appointment. So if you come in and you fell off your roof on Sunday afternoon fixing your roof or working on something, you may have a shoulder injury. Hey, we really need to get you to an ortho or a specialist, whether it be a cardio situation or whatever the case may be, is our nurses and our MA will make that appointment. We'll help that employee find the right physician and make that next appointment. Which, now that employee doesn't have to go back to the desk, one, try to figure out who to go see, and then two, make those numerous phone calls, get the voicemail, whatever the case may be, in order to make that next appointment. So we think that's very beneficial also, just as a time saver and just adds to the employee experience on both sides. It goes back to Dan also says, one thing that I've seen, been there 5 years, and out of our nurse practitioners, we've only had turnover once. So the ones that have come that were hired when we were originally hired, we have one that left the state of Tennessee. He moved back to the state of Kentucky, but they want to stay because it is a situation where they enjoy it and have viewed it as a partnership. Even though they are, working for the vendor themselves, they definitely feel like they become part of the lab, part of the culture, know the employees, the ones that come in and see them many times, and also don't feel the stress of, hey, I've got to see X number of patients in an hour. So they've stuck around also in a day and time where turnover has been very prevalent, especially in the healthcare community.
Thank you, Joe. How do you change your patient experience in providers?
Well, first off, when I first started doing this, I was trying to run a family practice and work with Nucor. And the problem was that you were pushed into practice to see so many people that it was almost impossible. You were losing money because of all the overhead. So you were pushed there. Whereas when I started working with Nucor, it was all based on value. What can we do to take care of these patients? So I think it's a lot more individualized and personal responsibility for that patient's welfare. And my father practiced medicine for 57 years, and he told me one time, he said, son, send your patient somebody to see yourself. And so I have a lot of good consultants that I can reach out on my cell phone or whatever, and instead of it taking 3 weeks, 4 weeks to get a specialty appointment, I get somebody to see sometimes the same week or within a week. I had a hematological problem on Tuesday, and he's going to see the hematologist on Monday. So if you have somebody that's an advocate for the patient, and that's what I feel like you really have in those site facilities. You got somebody there that really knows you as an individual and is going to take personal care.
Thank you. So Joe, I'll start off with you again. How do you develop, maintain, and increase utilization? How important is education, marketing, and communication?
Well, the utilization and marketing, if it's positive, is really good, like I was telling the story initially. And then if you run into a negative campaign, it's really hard to recover from that. I send out, I will send out periodically in the know with Dr. Joe and have various things, like we'll put that out for influenza vaccine, we're going to try to get pushed. And probably most of the people here will agree it's hard to sell immunization these days before COVID. And some things have changed, but we don't really send out mailers, and there's some things that probably could be done or should be done in the future, but probably the larger divisions of the larger employers have that ability, and I think it'd be a very important thing to do.
Ken, how do you increase and maintain utilization, and how do you use communication and marketing?
So we work with our Human Resources Department to get the marketing material out there about any new initiatives that we're running, either mental health and the different services that I just mentioned. Just like I talked about in the very beginning, from the utilization standpoint, we're not waiting for the patient to come to us saying, hey, I'm sick, etc. We're reaching out to those individuals the moment they come onto our health plan. So, and that's different. I mean, we've had people who have told our staff, why are you calling me? I'm not sick. It's a different culture, it's a different mindset. So then that sets the tone of, okay, hey, they understand that we're going to reach out to them. Where are we starting with? Are you a diabetic, hypertensive, HIV, thyroid disease? Welcome to America. That's unfortunately some of the cases that we're dealing with, where those individuals don't even know that they're diabetic. I think it's what, 20% of Americans don't even know they're diabetics? Well, that's what we're looking out to, that's what we're looking to find. Mr. Rosen hires them, and we try to fix them, because many of them have never even seen a physician before in their country. Some of the average ages that are coming to us are in the 60s, 70s, working as housekeepers or security or whatever it might be. We also look at who hasn't been here for, say, that year, or hasn't gotten the physical. We're also looking for, we have a compliance report, a medication compliance report that I can drill down all the way down to the patient level, and then our medical director and our team can reach out to those individuals. Hey, what's going on? Why aren't you being compliant with your diabetes med or whatever it might be? So that we can find out, is it just a lack of education and understanding, because some of the population believe, oh, I took it for 30 days, and hey, my high blood pressure's cured. And so we've got to continue those follow-ups. Same with our physical therapy department, our chiro department, everybody's doing those follow-ups, so we maintain that, not really the utilization, but just making sure that the patient's getting everything they need to be compliant and to keep them out of the hospital and keep them productive, reduce absenteeism, increase presenteeism.
Thank you. Dan, how do you develop and maintain utilization and role of that communication?
For us, it really comes down to the initial, when you're first going to open up a clinic, that's when the communication piece is the most important. And there has to be a two-phased approach, in our opinion, on how we're going to do that communication. First, as an employer, it's the introduction of, hey, we're going to bring this service to you, and this is what it means. And then you work with your vendor, and they put out a lot more professional marketing material than what typically your HR staff can handle. And they put out the material that really talk about, hey, who they are as a vendor, what type of services can be offered at the clinic. And that helps then create that buzz within the workspace for when that provider does come on site and get to provide services, because you want them to be able to hit the ground running. And then from there, it really comes down to, are there certain areas that we want to hit, or are we introducing a new service? For instance, when we introduced sleep studies, that wasn't something that we didn't tell anybody about. We let people know, hey, this is a new service that's coming on. So again, you work with the vendor that's going to educate what's going to be out there, and then the employer also puts out their own education campaign to make sure that if you're going to introduce it, people are going to know about it. But I'm sure, everybody else recognizes this, that you can tell them 100 different ways, and you're still going to get people that come back and say, I never knew we had that. We had it for 10 years. But there's no such thing as over-communicating with these services.
Finally, Scott?
So a couple things in this area. With our wellness program, I have a wellness consultant on my staff, and she works with our clinic a lot to try to figure out, hey, what do we need to tell our employees? And we have several auditoriums around campus, and our medical director will give, we'll key them in with all the other things you hear in the news, like National Heart Month in February. So she'll do a talk on that, or we'll bring in an outside cardiologist to do that, just to keep people awareness up. We're also in growth mode, so just 3 years ago we were about 4,500 employees. We're now 6,500. Plus we've had a lot of, we've had some turnover. So during our new employee orientation, we try to introduce people to the clinic, let them know where it is, how to get there. And then we also make them very visible at certain times of the year. We'll put them in the we'll put the staff, the medical clinic, and their staff, like in the cafeteria, and do flu shots. Like in September, we'll put them in the next couple of weeks in our cafeteria and do flu shots, but also be there just to communicate and talk about other services they offer. And we've also, in the last couple of years, we offer a premium incentive if you do certain things off your medical premium each year. And if you do a biometric screening and an annual physical, you're halfway there. So if you do that during the wellness year, you're halfway there. So we've really tried to focus people to, hey, know your numbers, get the basics, get your annual physical, and then also giving them the convenience of having that done there on site. It's halfway there. So that's kind of how we try to drive utilization through the word that way.
All right, fine. Let's go to audience questions we have. First one is, what do the panelists think about 51% of companies who have on-site clinics that do not measure ROI?
I mean, I think that's personally for me, that's kind of it's a hard number to measure because, what all you take into account. How do you measure that stroke that you prevented on Saturday because John came into the clinic on Thursday and we knew his blood pressure and they knew how to react and respond to that. So like I said, for us, measuring is a lot about the employee experience, the patient satisfaction, and then are we treating the things we need to be treated? And are we discovering the new things that need to be treated today as opposed to in the emergency room 2 weeks from now?
Scott, give me 2 measures of success that you have to get.
So patient satisfaction is one measure of success. And then, we do look at, and it's really been hard to look at over the last couple of years because you have to look at, our CFO and our CEO likes total cost. But with the addition of about 1,200 people, it's hard to look at our total medical cost. So you try to break that down to them on a, per member per month basis. But it's a little hard for them to grasp a little bit, but we do look at total cost.
Gotcha. Dan, what are your key measures of success?
We do look at ROI, but we also look at other things, for instance, chronic disease management. Diabetics, we're going to try and look year over year, the same diabetics coming back and are their numbers looking better. Also, the number of people with a chronic disease, how are they being managed at the clinic? So it's not just all about, hey, can you show us that ROI? Because like was said, it's a difficult number to measure, and it seems like you can measure it a dozen different ways. And while we keep looking at different ways to measure that and try and get as accurate as we can, we also want to look at some of the other things associated with calling a clinic a success. And some of that comes down to, are your chronic disease are being monitored and improved on from year after year. Your diabetics aren't getting worse, they're either stabilized or getting better. And can you measure that?
Great, thank you. Key measures of success. How do you measure?
Yeah, surveys, net promoter scores, looking at just the lives that we touch. When we look at keeping our cost as affordable for our patient population, where our population doesn't have deductibles and co-insurances and things like that. If we didn't control our healthcare spend as well as the entire team has, then we'd be doing things like everybody else, the cost shifting, and then that leads to where 35% of Americans can't afford healthcare. So from a success standpoint, it's still controlling and making it affordable for our population, and then also just the experience of our population.
Joe, how do you measure success?
Well, I really haven't, and I hadn't been asked to, and I don't know whether it could be done in my setting where I am so small, and I don't have the demographics that maybe Ken's got. But at the end of the day, what's the value of human life? So, how can you get a ROI if you say, well, was his life worth $1 million, or was it worth $150,000? Because what we do in the setting that I'm in is we really have saved lives. We had a person that came in with basically dragging his left leg, and I said, Jim, you got to get to the hospital right now. He said, well, I'll be all right. Well, he ended up having a near total occlusion of his carotid artery, and he would have been basically, he finally retired at 74, but he would have been, completely paralyzed on one side of his body if he hadn't had action done that day. So I think I love to look at all the ROIs and think it's a great thing that we're doing, but like I said, I just know we're doing the right thing, and I think the Nucor supports doing the right thing, and it would be nice if it was an easy way to measure.
It's a lot of fun when we hear many of our associates, and we have a great retention rate for being a hospitality business, so that's a measure. One of the things that I also love hearing is when our associates are saying, hey, they stayed with us not only because of the culture of Rosen, but because of the health benefits. That's a measure. I got to tell you, just like Dr. Joe's talking about, I'll never forget one of my first real patients, and we kept him alive for, I think it was 20 years. He had a heart transplant. We were able to do many things. He was challenging. 20 years. He finally retired from Rosen Hotels and went on Medicare. What do you think happened? He died 6 months later. That's the value you guys are bringing to your on-site health centers and the value of your insurances and everything you guys are doing. It's about the lives.
Thank you.
Take that ownership. That's what y'all do, that's what we do.
So, a question from the audience. Each of you decided on a management approach, self-management, a third-party vendor, health system. How did you decide which management approach, and how did you identify a third-party vendor if you did that? Joe, you self-managed. So,
I mean, it literally just happened. I mean, it's one of those things. I mean, I'll tell the story because it's worth hearing. So I was in Mount Pleasant, which is just north of Charleston, and they were building this big plant, Nucor was, and I kind of, it was the new kid on the block. I left the ER and come back to do primary care, and I kind of started seeing some of the physicals for the plant out there. But one of the patients that came by was the general manager. His name was Ladd, and Ladd decided, Mormon, they had 4 biological daughters, and they adopted 4 Eastern European sons. And so Sally and the boys, we could see me all the time, and Sally was like, Dr. Joe, you got to do a physical on Ladd. Dr. Joe, you got to do a physical on Ladd. So I had a nurse practitioner out there, and I got to do an EKG in his labs, and one day I said, y'all lock the gates, I'm coming out to do a physical on Ladd. So I went into his office, drew the blinds, and we did his physical right there. And he took it in good stride and said, Doc, what would you think about coming out here and doing these on our team? I said, sounds good to me. So we literally walked from there to human resources, the control was in there, one other person. So I tell you what we're going to do. We're going to have Doc come out here. We're going to do wellness exams on site, on shift, and waive the copay. Well, the copay was $25. Out of 900 people the year before I started, only 95 people had done a wellness exam. And I did 375 in 9 months. And during that period of time, we picked up leukemia. It was so early they had to do a bone marrow biopsy twice to confirm the diagnosis. Found prostate cancer, and it just became a real initiative to keep building it from there. And so it's been a real exciting thing to have been able to do this in my career.
thank you. Kenneth, how did you decide? Did you self-manage, and how did you decide?
Again, Mr. Rosen said to do it. I mean, it's able to do things on his own. But what I really love is how, we're self-funded, we control our health plan, but the integration between the health plan and the medical center and that coordination is key. We're able to see things in the medical center, and then we can go right back and make changes on our health plan to make it more accessible or easier or cheaper or whatever we need to do to increase the access and increase the utilization for our members and to keep those chronic care conditions under control. The beauty is, yes, we have Ozempic on our health plan. Well, guess what? Our medical center, if we write it for weight loss, we will cover it 100% for that member. I know that's still controversial out there with everything that's going on, but if it's the right thing to do and if it's going to help us in the long run, then we'll do whatever is needed and whatever the right thing is to do.
Thank you. Dan, how did you decide?
One comment I did want to say that Nucor is self-insured. So, basically, there's no vendor that I have, and I don't submit claims or anything else. It's just basically what we can do to try to save the division money. It's a 1/3, 2/3 from the first dollar, and then there's a stop loss. But Nucor takes over the responsibility of the self-insurance model.
Dan, how did you pick your model and how did you pick your vendor?
For us, we're not with the vendor that we first started with. When we first started primary care, we had a wellness vendor. They provided health coaching, but they had also do on-site primary care clinics. So we said, okay, well, we're already a vendor, so we'll go ahead and start running our clinic. And part of that was because we really didn't know what we wanted in a primary care clinic at that time. So we started down that journey, and as we went, started to get more comfortable with how we wanted that clinic to look, what services, what data we wanted to have, and we realized that the vendor that we were using at the time couldn't provide a lot of that. It really came down to kind of square peg round hole wasn't a good fit. They said, no, this is our model, and this is what we're going with. And I said, well, this is how I want it to look. So at that time, we said, okay, this isn't going to be a great partnership. You're good at what you're doing, but I want to look at something different. So we went up for RFP for that. We actually, for a little while, thought about doing some self-management. Going to form a separate LLC, and after reviewing that for a couple weeks, we said, no, what are we thinking? We're not cut out for doing that. We're cut out for making chicken. So let's make sure we stick to what we're good at, and we'll bring in some professionals that are good at this. So we went up for RFP for that, and identified the vendor that met exactly what we were looking for in regards to, hey, this is how we want a clinic to look. This is the data that we want to get back. This is how we want to talk about ROI. This is how we want chronic disease. This is the services that we want. And then from there, it was easy once we looked at what we wanted. And for us, it was a learning process. We had to go down and have some stumbling blocks first, and then really define, hey, this is what we want for a clinic. And then from there, we identified it.
Thank you. And finally, Scott, how did you approach your management selection, and how did you pick it up?
Never thought about self-management. We truly were going to third-party vendor from day one, and we did an RFP.
All right, we are out of time. Let's thank our panel for